This diagram illustrates the biological baseline for human consciousness. A patient must meet 3 requirements to be conscious. They must be awake, meaning they can be roused by touch or sound. They must be alert, capable of understanding their immediate surroundings. And they must be oriented, aware of their identity, their location, and the current date. Consciousness relies on this fragile mechanical system remaining intact. When the circuit breaks, the patient is trapped in the silent void between life and death. From the moment an unresponsive patient arrives, the clock is running. Brain tissue may be taking irreversible damage by the second, yet the one person who could explain the symptoms is locked out of their own body. To save them, medical teams must interpret the body's physiological signals. They have to piece together a sequence of internal failures using only the physical evidence left behind. For generations, physicians have had to stand over a motionless patient and attempt to deduce invisible trauma. Without the ability to simply ask what happened, they rely on intense observation to trace symptoms back to their source. Translating these signals is a literal race to stop permanent brain death. Every minute without an accurate diagnosis allows vital neural pathways to wither. This anatomical map shows the internal hardware system generating human consciousness, relying on a 2-part network connecting the brainstem to the outer cortex. Down at the skull's base, the reticular activating system maintains raw wakefulness, projecting upward into the cerebral hemispheres, translating into awareness. If the power switch is working, but the processor takes severe damage, the patient enters a vegetative state. Their eyes might open and close with sleep cycles, but they lack cognitive function. They are awake but unaware of their surroundings. But if damage strikes both the cerebral hemispheres or severely injures the reticular activating system, the system crashes. This total failure results in a deep, unarousable coma. A coma is a catastrophic physical breakdown of the biological wiring that allows us to perceive reality. However, an unmoving, unresponsive patient isn't automatically in a coma. Doctors must quickly differentiate a true coma from a few harrowing imposters. In locked-in syndrome, the cerebral cortex is active. The patient is aware and thinking clearly, but damage to the motor pathways leaves their limbs and lower cranial nerves paralyzed. They are trapped inside a motionless shell, often communicating only through vertical eye movements. Another imposter is stupor. At first glance, the patient appears unconscious, but they can be forced into a brief window of awareness through intense, repeated physical stimulation. Failing to distinguish between these states has horrific consequences. A misdiagnosis could lead a medical team to treat an aware, terrified individual as if their mind is already gone. To find the cause of a coma, physicians organize the investigation into 3 main categories: structural brain injuries, a severe infection, or toxic metabolic emergencies. This angiogram displays the complex vascular network of the head and neck. If a patient experiences sudden vomiting combined with extreme high blood pressure, doctors know exactly where to look. Those specific symptoms point directly to a catastrophic structural event, like a cerebral hemorrhage. Conversely, an exceptionally slow heart rate shifts the investigation away from physical trauma. It suggests a toxic cause, like an overdose of antidepressants or a dangerous spike in intracranial pressure. Even a patient's breath holds evidence. A distinct musty odor or a sharp fruity smell can expose an invisible metabolic crisis, such as liver failure or diabetic shock, flooding the bloodstream with toxins. The comatose body broadcasts its own failure through vital signs, reflexes, and chemistry. The physician's job is to read that data before the damage becomes permanent. Pop culture frequently portrays patients waking up from a coma by simply opening their eyes and immediately resuming normal conversation. The clinical reality is a grueling, disorienting climb. Physical wakefulness almost always returns long before cognitive awareness does, leaving the patient in a confusing twilight state for days or weeks. To bridge the gap between being biologically alive and being aware, the brain must painstakingly rebuild and rewire its damaged internal connections. Surviving the initial trauma is only half the battle. To regain consciousness, the brain must reestablish its fundamental operating processes. human consciousness exists as a highly mechanical, physical network of biological circuits. That network relies on a delicate balance of electricity, oxygen, and chemistry just to maintain moment-to-moment awareness. A single ruptured vessel or a chemical imbalance can plunge the entire system into darkness. While modern medicine continues to map the dark edges of this neurological twilight zone, many of the mechanisms the brain uses to repair itself remain shrouded in mystery. Until science fully charts the boundaries of the mind, a methodical investigation into the body's failing hardware remains the only weapon to pull someone back from the void.